So I want to just make a small disclaimer ahead of time. This talk is focused on young women, but I don't want to exclude anybody who may not necessarily identify gender-wise, but this talk might still apply to. So this would include anybody who would perhaps consider themselves non-binary or transgender. But so this talk is more broadly to say that our nomenclature in GI has not quite caught up to the advances that are being made, but this is to be an inclusive talk. But for the case of nomenclature as it stands right now, I'm going to use male, female, and woman, man for most of these slides. So why is this particular talk important, right? You've already seen all the data that has been beautifully presented. You're going to see a bit more of a practical kind of approach and sort of a deeper understanding of why is this an important topic. So you know this, but like inflammatory bowel disease, it typically occurs in patients, and when they get their onset of it, they're in their teens, early 20s is the more recent data, right? And then you can see here that in the United States, pregnancy tends to happen slightly after that. For most patients, they get pregnant. So sometimes, we want to just take a step back and say, even if this patient is not necessarily considering pregnancy at the time, it is something that a lot of women will have in their mind when they first get diagnosed is, how does this going to affect the rest of my life? How may this affect my potential family planning or not? Not for everybody, but I do think it's an important point to kind of consider when you do see women early on. And this particular slide I love because when we see it up here, we get so excited. We're like, look at all these new medications that are out there. But I fully recognize that maybe some people who are sitting in the audience might say, oh my gosh, look at all these new medications that I now have to consider. And I already have a busy clinic practice. And this is just another one that I have to kind of really learn. And how does this affect maybe a specific patient population? So it's an exciting age. And I think that that's how we should look at it, is that it is a really exciting age to be an IBD. Look at all these wonderful new medications we have, or combinations of medications we can do, or these nuances. So you really have the ability to personalize it to the patient that is sitting in front of you, and what a privilege that is compared to 10 years ago, 15 years ago, 20 years ago. So this is a really exciting age, and I really want all of you to sort of think about that mindset when you see an IBD patient, all right? And be excited to take care of them. But I will also say, as I run a pregnancy clinic here, that misconceptions are incredibly common among patients and providers, and I think even more so with the newer medications that are out there. So we really want to kind of take a step back and just talk about, what some patients' perceptions may be. So I'll focus a little bit more on pregnancy in the first half, and then the last half of the talk we'll talk about non-pregnant related issues. But a lot of women sometimes just think, medications are maybe harmful to my baby, or I can put up with the symptoms as long as I know that my baby is safe. And then what I really want you to do is kind of push back and say, just as we do for non-pregnant, is like, what are the risks of uncontrolled disease? All right. So in pregnancy, we know that there's serious consequences to this. So we've had long-standing data earlier from Europe with the big registry studies there, and then now within our own US piano registry that shows that, even if you are perfectly controlled, not a spot of inflammation on any biopsy, and you get pregnant, you're still at a slightly higher risk for preterm birth, all right? So this is our well-controlled patients. Nothing goes wrong with them. They do beautifully, but they still have a preterm baby, a baby that is born less than 37 weeks. So for this reason, all of our patients are high risk and should be followed as such with the high-risk colleagues for the OBGYNs. But if you are actually pregnant and you have a flare during pregnancy, or you go into pregnancy with less control, there is much higher risk for preterm birth, low birth weight, and unfortunately miscarriage and stillbirth. So we really want to kind of push back to say that if somebody is considering pregnancy and maybe they don't want to be on a medication because they feel like it's unsafe, to say that there's actually more risks with being uncontrolled and going into pregnancy than being on a very safe medication. So let's just say, generally speaking, let's talk about some of our older medications. What's safe and what's not? We know for sure, everybody knows this, the methotrexate and thalidomide are not safe in pregnancy. So unless they come from a sort of a pediatric population, not many of our patients these days are on methotrexate, and hardly anybody's on thalidomide anymore. So the mesalamines as a whole are completely safe. Thiopurines as a whole, really honestly, are very safe. There was some earlier data, a couple decades ago, looking at sort of, a fetal anemia, but that has not really borne out to be true in the era of being able to use drug levels to check these things ahead of time, and also in the newer data. So, and then biologics as a whole are safe. These are the biologics that we've had for quite some years now, and those have all proven to be quite safe. And then steroids, again, they have their other risks, but generally speaking, if you need to use them in a pregnant patient, please do. The risks of uncontrolled disease are greater than the risks of the steroids at this point. So then how about some of our newer medications? There is more limited data with the newer medications, but generally speaking, we do consider risankizumab and mirikizumab as very safe. And we do not, I'll go into more details about the JAK inhibitors and the S1Ps, but at this point, we do not consider those to be safe. So let's take a look at some of the data that we do have in JAK inhibitors or the S1P agonists in pregnancy. So in human data, granted, it's not a lot of data, but in human data, we do have a mounting evidence that shows that at least in animal studies, we've already known that they were teratogenic. So the defects include anasarca, membranous VSDs, and skeletal defects. But now looking at in the human data, we do see that there's an increased risk for congenital malformations for TOFA at the 6 times the max human dose. But in general, in the doses that we tend to use it for, so 10 milligrams twice a day or 5 milligrams twice a day, we don't see necessarily an increased risk, but again, the numbers are quite low still for this. For UPA, this is one where I want to kind of point out that there is an increased risk for congenital malformations at the dose that's matching the lowest human dose, so at the 15 milligram dose. So you do have to be a bit careful especially with UPA in pregnancy. And then ozanimod at all doses, well, there's one dose for it, once you ramp up, that it does seem to have congenital malformations and fetal death. So with the S1P agonists and the JAK inhibitors, there are also what we call small molecules. They cross freely into the placenta in the first, second, and third trimester. So we really should be very cautious when we choose who we're going to counsel to put on these medications and make sure that they are on very effective contraception. This is not a pregnancy talk. Happy to give a pregnancy talk in the future, but I wanted to leave you sort of with one slide that really shows that our overall approach to management and monitoring pregnancy, which was really nicely done. And the main thing I want to kind of point out is what's at the very top of the slide, right? The second one. You really want to make sure that they are in steroid-free and endoscopic remission before conception. If you get them to that point, you will tell your patient, and they're on a safe medication, that that is the best chance that they have at having a healthy mom, healthy baby during the pregnancy. So really try to focus on that message well ahead of time of when they are planning to start a family even. So then once they do get pregnant, or if you're, as we'll talk about it a little bit later, if we are wanting to put this particular patient, let's say on UPA, that we have an exit strategy in place. Hopefully she gets better on UPA, and then hopefully at some point we'll discuss maybe another exit strategy for her, and that is safe and that she has demonstrated to be in remission, and at that time she's ready to go. Just really be very vigilant. See your pregnant patients at least once a trimester if they're doing really well. Follow them with a fecal calprotectin, and then eventually, as all of us get a little bit more trained in this in the country, perhaps even intestinal ultrasound as an additional mode for monitoring during pregnancy. And then really just be in contact with their OBGYN, and so everybody is on the same page and everybody feels comfortable with this. But I'll leave you with that. Now, in our particular patient, we're considering putting her on a medication that we know is teratogenic. We know that it is not safe. So then I think we need to think about it on our end and not just leave it to the OBGYN to say, we're going to actively put you on a medication that we want to make sure you do not conceive on, all right? That there minimizes the chance of an accidental pregnancy. And how should we do that? So I do think we should make a couple of suggestions to the OBGYNs just from our behalf. We don't have to go too much in detail about it, but I want to just go over some of the contraceptive methods that are offered this day and age, and why some of them are better for our IBD patients than others, all right? So combined hormonal contraceptives, so these are birth control pills, all right? And they're also things like a NuvaRing or a patch. Now these, if they have both estrogen and progesterone in them, that does, independently in people who do not have IBD, increase their risk for blood clots. all right? And we also know that patients who have IBD, especially if they're active, also have an increased risk for blood clots. So in this sort of situation, we really want to make sure that unless the patient is very, very quiescent, which this particular patient is not, we do want to avoid putting our patients on combined hormonal contraception, so those with estrogen and progesterone in it. And perhaps if there is some data on the JAKs that in other rheumatologic literature that they may also have a slightly increased risk for blood clots, we have to be extra careful of this. Now, one thing I will mention on there is that if they need to go on a pill for gynecologic reasons, something like endometriosis or irregular periods, the progestin-only pills actually work fairly well for that, and they confer a lower risk for DVTs, so that is something we could recommend for our patients. All right, how about what we should wholeheartedly recommend in our patients, unless there is some contraindication, is actually intrauterine devices or implants, so IUDs. All right, IUDs are kind of our gold standard of what we should recommend for IBD patients when they're thinking about contraception. And what is great about it is it is sort of a set it and forget it method for many years, and now even the newer ones that used to be only 3 to 5 years are getting approved for 8 to 10 years. So in this particular patient, if we are not looking to consider a pregnancy in the next 2 to 3 years, which honestly, it would be hard to get her well and switched over to something else within that time frame, we should recommend an IUD, all right? Now, behavioral barrier methods, they're very prone to high rates of unintended pregnancy, so we should not recommend those. And then how about depot injections? So depot is also something I want to highlight, that as an injection by itself increases the risk for osteoporosis in all women. And we know that our IBD patients are much higher risk for osteoporosis, given that they are on steroids frequently or just having active inflammation steals from the bones. So we really want to be mindful to avoid depot injections in patients. And if you think this is just too much, I cannot process the 50 clinical trials that we just showed as well as this, then there's a fantastic app that the CDC has that you're welcome to take a look at. And what is nice is not just for IBD, but it's for all conditions. So if somebody has cirrhosis, if somebody has, even just IBS or many different GI and non-GI conditions, this app will tell you what you should preferentially, refer patients to for contraceptive, okay? And then a couple of last things I wanted to kind of mention. So again, this particular patient, we are not looking to, consider pregnancy anytime soon. So what about, she may come to you and she may say, okay, I have been noticing that my periods have been irregular as I've not been feeling well or doing well. Or, so there's a lot of data that is upcoming that shows that the menstrual cycle changes can happen, especially when patients are not doing well. So a lot of people will have spotty periods, skipped periods, or just not have a period altogether for a long period of time. So those are very common. And although in the pediatric population, Dr. Hamandi will see this more, but menarche is usually delayed. And even in our patients who have menstrual cycles, you will see that oftentimes at the time of their initial diagnosis, if they look back the year preceding, there's been a lot of changes there as well. So sometimes they go to the OBGYN and they just run themselves in a circle trying to figure out what is going on, when really it's actually our area where we just need to get their disease under better control. So I just want you to kind of keep that in mind when you see patients for this. And then last two things I want to mention, this is also something I think we should be leading, is we check, we recommend other routine vaccines and routine health maintenance, but we want to make sure that we're doing the same for women for things like pap smears. So people who are on immunosuppression and have a cervix, they are at higher risk for abnormal pap smears and CIN2+ lesions if they're on immune suppression. So there was a older recommendation by the American College of Gastroenterology in 2017 to do yearly pap smears on this. There's some newer recommendations that have come out in 2019, reinforced in 2021 in the OB literature, that really shows that If they're on immune suppression, they follow an HIV guideline, and that particular guideline, I won't go into too much detail, but basically 3 gets you 3. If you get 3 annual pap smears that look good, then they go to every 3 years, and they've shown that that really has been quite effective. And then how about the HPV vaccine? We should also really be on top of recommending this for our patients. So a routine vaccine is recommended for anybody up to the age of 26, and then our patient definitely follows into this. And so since she's on immune suppression, you want to be on at least a 3-dose vaccine for anybody on immune suppression. And then the last thing I'm going to end with is that, body image and sexual health is really quite poor in all of these patients that we see. I have patients who well treated for numbers of years, right? And they still will have a hard time just, even having the thought of going out on a date or going out to meet people. It's just a very hard thing because they never know, or they feel like they never know when their symptoms are going to come back, or if they have things like perianal fistulas or prior surgeries or an ostomy, it is quite challenging. And I think we are so focused on getting their disease under control. And like Dr. Singh had mentioned on one of his slides, you really do want to look at the patient's quality of life and also kind of try to help them target these. So there was a survey that was done that really showed that it impaired 89% had some impairment in their quality of life. And that, especially for women, an impaired body image was almost 80%, And I think it's very challenging because sometimes, and I know your patients will also say this, people will tell them that they look fine on the outside. They look fine. They look like everybody else. And I always tell them, if they could only see what's going on the inside, they would not tell you look fine. But even when things do look good on the inside, they're still very, very scarred by what has happened. So really make an effort to, if you can, utilize a mental health professional to help them get back on the road. So the last things I wanted to kind of just leave you with is that, medication choice, just like Dr. Singh and Dr. Salk had really mentioned, is that if you have milder to moderate disease and you're bio-naive and you have lots of other things that, you want to kind of look into, maybe you want to travel and do an oral and injectable medication, maybe you're scared of things, you have many choices. But for people and patients like this, where it's severe disease and multiple medication failures, you really want to always choose the medicine that is going to work the best for them. And do not assume that if somebody has a uterus, they're going to use it. Just have an honest conversation about them with it and really take the time to counsel them specifically for this. And if they are not, planning on having a child soon, and especially if they are actively inflamed, please do talk to them about contraception and get them on something that is very effective. And then really just start to work with their care team, work with their gynecologist, work with their primary care physician, explore any referrals to mental health, because we're not just taking care of their colon. We're not just taking care of their small intestine. We're taking care of a person, and a person has a whole life that we want to be there to help them achieve and succeed as best as they can, because they really do look at us as we are their doctor, especially when they have IBD. So really kind of take that as an honor and really just, try to make the best choices as you can and best recommendations for our patients. That all.